Welcome to Women United's Candid Conversations, COVID-19 Vaccinations. As an integral part of United Way of the Mid-South, Women United fights for the health, education, and financial stability of every person in every community. To take us further into our program, please welcome one of Women United's leading ladies and Global Women United Leadership Council members, Reverend Marilyn Robinson.
We are so excited to have you join with us at our virtual COVID-19 Town Hall, a time for a candid conversation about the virus, the vaccine, and vaccinations. We do want to thank our sponsors this evening who helped us spread the word about this event. Local 24 TV, MLK 50 Justice Through Journalism, The Commercial Appeal, and of course, United Way of the Mid-South. It's my pleasure to introduce the presenter for the evening, Dr. Barney Graham. He was recently featured on the front page of USA Today for his role in creating one of the first COVID-19 vaccines. Dr. Graham is the Deputy Director of the NIH. He is over the Vaccine Research Center and Chief of the Viral Pathogenesis Laboratory. Let me say a word about Wendy Thomas, our moderator. She's the founder, editor, and publisher of MLK 50, Justice Through Journalism, a nonprofit newsroom in Memphis focused on poverty, power, and public policy. She's also a fellow with ProPublica, a national investigative journalism outlet. Wendy's known for her journalistic integrity, her commitment to getting your answers for questions that you have, and making sure that the public is properly informed. She is a phenomenal woman and a phenomenal journalist. When we made the decision to have our panelists on stage, we consulted with the Shelby County Health Department and referred to CDC guidelines. You will notice that our panelists are all wearing masks, except when they're speaking. They are absolutely socially distanced, more than 6 feet apart, and there is adequate ventilation in this place. So, as we begin our conversation, let's get ready for a real conversation about the vaccine, vaccinations, and you. Thank you.
This is quite an honor and privilege to be with these guests tonight. Actually, I think we're going to go to Dr. Washington. You're out in the community. You're leading an association of physicians that are well aware of the significant health challenges in the African American community. So I want you to talk to us a little bit about what you're hearing from your patients about their willingness to take the vaccine and maybe even some of their concerns.
The one thing that a lot of patients are talking about is that they really have concerns regarding how quickly the vaccine was developed. And so that's their main concern. They want to make sure that it is safe. And so just to lead by example has been one of the most important things. And I've received feedback from many people in the community that have said, you know, the way that you represented things about COVID-19, the way that you talked about it and made it more realistic was one of the reasons why I began to take it seriously. I watched what I did going out and about. I made sure to wear the mask. And I was initially afraid of receiving the vaccine. However, your chronicle of that you received the vaccine and talking about it has made me more comfortable with receiving the vaccine. And that's really our primary goal.
Absolutely. So let me ask you, Dr. Washington, as the vaccine was being developed, were you initially like, yes, I'm going to be first in line? Or were you even like, let's see how this goes. Tell me about your process.
Well, I will say that initially when I heard about the COVID vaccine development, I was thinking, oh, it's going to be a couple of years before we get a vaccine. So that was my initial thought. And to see that the vaccine development was so quick, of course, it was very encouraging. Did I have some questions? Absolutely. So what I did was, once the primary data was available, I looked at it myself. And once I saw that, it was very protective for patients that were included in the study and really reduced hospitalizations and deaths, I said, oh, sign me up.
Dr. Haushalter, I want to pivot back to you. When people say this vaccine was developed too quickly, there's no way they could get this together in less than a year. What's your response to that?
Even though it was completed within a year, it had to go through all of the typical processes for approval before it was approved for safe use in the community. So I feel confident in the fact that it was completed through the general processes that we know need to be done. And then also I agree with the comments that were made that it's important to role model as well. And so I am also vaccinated and try to share that with others so they feel more comfortable.
Speaking of role models, that takes me to Pastor Norman. As it's been said, you're a pastor, you're an executive at a hospital, you're a member of the COVID task force, and you're interacting probably with more people in the community, certainly than I am, on a day-to-day basis. Our activities that was dramatically curtailed during the pandemic is church attendance, right? That was discouraged. So talk to me about how your church dealt with that, and then also what you've told other pastors who are grappling with whether to have service in person or do it virtually.
Well, thank you for the question. Immediately on the first day, as a matter of fact, Dr. Haushalter and I met at the health department, and we knew that this meant that church services would be disbanded. I reached out to my colleagues in a very large circle here in Memphis and began to explain to them everything that I understood, both from the healthcare perspective and what this meant to large congregations, especially gatherings of a public nature, while also recognizing the social implications of how African American people especially receive information. I knew that we would have to build systems of communication to reach out to our parishioners. And so our virtual services took on more than just the nature of worship, but they really became information formats where we would take the information from the health department. Oftentimes I would have Dr. Bruce Randolph and others to come to our church, come to our Bible study, and to share with people what was actually going on.
Dr. Nate, I want to turn to you. The vaccine is now being distributed at pharmacies. So not the pharmacy you work at yet, Walgreens, but at Walmarts across the region. And so you have contact with people coming in, trying to get their prescriptions. What are you hearing from them about the vaccine?
As my colleagues have all said, there's a concern about the safety of the vaccine. You mentioned the word hesitancy. Even in my pharmacy, so I have about 15 technicians that work with me as well as other pharmacists. And when I mentioned that we're eligible, we can go out and get the vaccine, I had a couple of So I said, if anyone has any questions, they're on the fence about the vaccine, come and see me. And just like the patients, they just have questions like, was it developed too quickly? Can you explain to me how they developed it so quickly? Is it safe? Is it effective? And like Dr. Washington said, we looked at the information, we looked at the data. We looked at the science, and the science said, yes, it was developed quickly, but there's a reason for that. And we have the reasons, and we know why it was developed quickly, and we're able to say it is a safe and effective vaccine.
Another one of the questions I've heard in the community is, does the vaccine change your DNA?
So the vaccine does not change the DNA. The COVID vaccines that are currently available, the Pfizer and the Moderna vaccine, are messenger RNA vaccines. So nothing is incorporated into your DNA. The vector that is used for the vaccine is injected into your arm, and your body creates an immune response to that vaccine, and then that waste is excreted. So nothing is incorporated into your DNA, and so that's something that's very important.
Okay, here's another question. Does the vaccine make you sterile?
This vaccine does not affect fertility at all. I will also speak and say that I am a woman of childbearing age. I had no hesitancy when I received my vaccine. A lot of my colleagues as well, they didn't have hesitancy. Many of my colleagues are pregnant right now. They received the vaccine while being pregnant.
You know, I was raised in the church, and there was always, the talk of the mark of the beast, right? You never want to take the mark of the beast. Is there something in the liquid that's being injected into you that could be used as a tracking device?
I think what people are hearing is the term new technology, and they're hearing nanoparticle, and they're hearing it in rapid succession. And to me, that sounds like nanotechnology. And, I watch the Marvel movies and everything like that, and you hear that type of stuff all the time. What it is, yes, it's new technology, but a nanoparticle is simply a measurement of size, just like saying a gallon of milk. It's just a very small particle, and this new technology is actually used in some cholesterol medications. Some of the new injectable cholesterol medications, it's just very, very small. That's all it is. There's no actual chips or anything like that at all being injected when you get the vaccine.
I've heard people say, how could they come up with a COVID vaccine in less than a year? They can't even cure cancer, right? And so, can you talk to us about that process?
We've been working for the last 3 years on something called the prototype pathogen approach to pandemic preparedness. So we had already made an mRNA vaccine with the stabilized spike protein of the MERS coronavirus and shown that it could be protective against that MERS challenge in animal models. And we'd also done it with some other virus families. So when this outbreak was announced, we agreed with Moderna, they agreed with us that this would be the time to do our demonstration project and show people how fast we can go if we know what to do ahead of time. And so the day the sequences were released on the 11th of January, the next morning, that Saturday morning, we designed all the reagents we needed, all the assays we needed, how to make the protein, how to make a vaccine. And by the next Tuesday, on the 14th of January, Moderna started manufacturing because we had a trusting relationship, and they trusted that we were making the right protein. And as we went, the vaccine worked in mice, the vaccine worked in monkeys, the vaccine worked in people at the small stages. And as we went up to larger numbers, when we did the experiment in what's called phase 3, the large trial where 15,000 people get the vaccine and 15,000 people don't get the vaccine, we found that against symptomatic coronavirus disease, it was 95%, 94% effective.
So it sounds like there was already a team that had been practicing together and working together on this kind of technology, this kind of a vaccine. That would be the government and Moderna. And you were already maybe on third base when the COVID virus emerges. And so getting from third base to home did not take you as long as it might have if you were just starting from scratch, didn't have that relationship, weren't already working on this sort of vaccine. Is that accurate?
That's accurate. And then the other thing that changed was the government put a lot of money into this, so it took away the risk of money. Ordinarily, in a vaccine program, you do things serially because you don't want to put your money and time at risk. But in this case, because of the crisis, the government put a lot of money into this, and the companies could operate and only pay attention to safety and efficacy. And so all the different stages of development were compressed and done in parallel. And the data package for this vaccine, for all the vaccines, the Pfizer vaccine, the Moderna vaccine, and the Janssen vaccine, are all extraordinary compared to some of the other vaccines I've seen happen over the last 35 years. So there was no shortcuts here on testing, especially for safety.
Talk to us a little bit about herd immunity. What is that? Why is that important?
So I'm illustrating here on the bottom panel that the blue people on top are not immune. and the green people on the bottom have immunity. And so when a virus meets a population without immunity, a lot of people get infected. Those are the red people. And it has a high transmission rate. It's much lower when you have the immunity. And the problem with high transmission rates and a high force of infection is that you're going to also have more severe disease. And that's what we're having now with a high mortality rate, especially in our older patients and people with other risk factors. And you see in the bottom, the immune population, even though there's infection, the disease is much milder. And the way herd immunity works, or population immunity works, you see the blue couple in the middle on the right lower cluster. It's completely surrounded by immune people. And the red person at the top of that cluster is completely surrounded by immune people. That will break the transmission chain. The red person can no longer infect the blue person. So population immunity means that you are protecting each other.
Dr. Parisi, welcome. Got a few questions for you. One of them is, if you leave out the U.S. territories such as Puerto Rico, Virgin Islands, Tennessee is tied with Utah and Georgia for last place based on the number of vaccine first doses given. Even when it comes to second doses given, it's still near the bottom. Why?
We came out of the gate really quickly on first doses, and we're one of the national leaders in second doses. And so we dropped off in first doses, but that's not the whole story. There is a well-known trade-off in equity and speed. In fact, there was an op-ed in the Washington Post, I think it was a couple of weekends ago now, talking about that very phenomenon, in so much as when you get it to populations who are most vulnerable, you by necessity have to slow down. And you will remember that our plan has been lauded nationally on multiple occasions and by many different entities, both in the former presidential administration, as well as the Boston Globe and MIT, Harvard, the School of Public Health, as being one of the most equitable plans in the nation. I will just kind of level set, though, in overall doses. It's been a couple of days since I've looked at it, but last time I looked, we were number 20 overall in the nation in total doses administered. When you look, I believe we're the 16th or 17th most populated state, so that's pretty consistent. We now have about an equal number of people that have had first doses and second doses, over 800,000, and right at almost 11.6% of our population immunized. So we're getting there. Equity is one of the reasons that we're going slower, because we want to get it to the people who need it the most.
So you mentioned the state's plan and its focus on equity. And I think that's interesting, because if you actually read the plan, the word African American or Black doesn't mention once, right? So it doesn't come up once. They talk about vulnerable populations, socially disadvantaged, but as we know, that can often leave out Black people because of the failure to be explicit. Black residents make up 17% of the state population and only 7% of vaccine recipients. Help me square that with what you just said about the most equitable plan that's been lauded by the president. This was the prior administration, and then also Boston Globe. Help me square that.
Sure. Equity means getting to all of the communities in an equitable fashion. So let me tell you what equity does not look like. Equity does not look like only having vaccine in multiple mass vaccination sites where people can't get there, particularly in a very widespread and sparse, often rural geography in Tennessee. Having mass vaccination centers in a few of our larger cities does nothing for an equitable allocation geographically. You also have equitable allocation in communities of color, just as you mentioned. One of the highlights of our plan that has been most highly lauded is our social vulnerability index. This takes into factors such as race and income, as well as socioeconomic status of the zip code and even down to the block. It is a nationally produced index that shows us where our most vulnerable spots in Tennessee are. We are one of the only plans in the nation that actually prioritizes allocation into those zip codes and even down to the block level in some instances to get to those that are most socially vulnerable. Again, not only for race, but also geography and then age. We also prioritize those, as you've seen in our plan, those who are at most risk based on their age.
You spoke just a second ago about getting the vaccine to the people who were most vulnerable and those being elderly. One of the things that Dr. Haushalter raised before you joined us is that we know, data shows, that Black people are getting infected and dying of the disease at ages, on average, a decade younger than white people. And so if equity is a concern, talk to me about the decision not to adjust the age threshold in some way to account for the fact that Black people are dying at younger ages of the disease. Because that was a decision, as I understand it, and I want to understand how you made that decision.
But I believe the point she was trying to make is people of color, their life expectancy is shorter than that of Caucasians. And so therefore, when you prioritize by age, by necessity, there are less people of color because their life expectancies are longer. That is understood. It is also very well documented that the risk is based on age, and our plan is very risk focused. Not only healthcare infrastructure, that's why we prioritized our healthcare workers first, but also those with individual health outcomes or at risk of poor individual health outcomes. Let me be crystal clear. If we had unlimited product, there would be no question of who could get it. Everybody could get it. That's exactly what I would want. But when there is a limited supply and when the demand greatly exceeds the supply, by design, you have to prioritize it. And in our state, it is an age-based prioritization because that is where our hospitalizations and deaths are. Fortunately, as we are now getting down into lower age brackets, we are, and Wendy, you may have made the point, or somebody else may have, that we are starting to see those numbers grow in our communities of color as we get down in lower age. So I continue to see that number grow. That's encouraging to me. We are currently in the 65 plus and 1B or teacher category. We know that communities of color are represented more heavily in those groups. And so we're looking forward to that number continuing to grow.
Thank you for that. I think we're at the phase of the program where we're going to ask everyone just to give a final thought. What's the takeaway? What do you want the audience to leave here knowing, understanding? We'll start with you, Dr. Nate.
Everyone at home, if you haven't picked it up from everything that's going on here and everything that's been said tonight, get signed up, get any vaccine that's available to you as soon as you are eligible. If you're on the fence, we've given you lots of good information. There's more good information out there, but please get signed up, get the vaccine, anyone that's available to you once you're eligible.
Dr. Washington.
Make sure that you are well educated about what COVID is, what it can do, as well as the long-term effects. Again, we have provided a lot of information about the vaccine. There is a lot of information that is available online, on the local news. Make sure you're using reputable sources and make the decision for yourself. Talk to your personal physician. Talk to your friends, family members. If you have received information and your mind has been changed about the vaccine, or if you're feeling more comfortable about the vaccine, make sure you share that with the people in your circle, because by doing so, you are keeping your community safe.
We can't fix yesterday. We can have a better outcome tomorrow when we all take advantage of making sure our personal health, our movement towards the group population immunity factor is being met. That's going to take a collective effort of every individual taking personal responsibility and then going forward in that direction. I know there are a lot of conversations about who's on first, who's doing this, or whatever is going on. The most important thing that we can do right now is to make sure that we get the information, make a well-informed, faithful decision, and get the vaccine.
All right, we definitely want to bring in Dr. Piercy and Dr. Graham. So Dr. Piercy?
I would reiterate exactly what my fellow panelists have said. The best vaccine is the first one you can get. And so please do that at the first opportunity you have. But also don't forget, this isn't over yet. It's not a get out of jail free card. You have to continue the precautions until, as Dr. Graham said, our community is immune. That means continuing to watch your distance and wear your mask and wash your hands. I know people get tired of hearing us say that, but it's really important to continue this. This is going to be here for a little while longer, and until we can get our community immune, we have to continue those precautions. And one final encouragement, if you have gotten your vaccine already, help your neighbor, help your family, your church members, your family and friends. Help them get scheduled. Help them arrange for transportation or take them to their appointment, and we can all get through this together.
Thank you for that. Dr. Graham?
Within 3 to 5 years, probably everyone is going to have immunity to this virus at some level. And you're either going to get that through an infection or you're going to get it through a vaccination. The infection has a 1 or 2% mortality, and higher than that if you are older and have risk factors. And but also it has about a 20% chance of long-term side effects. The vaccine has about a 3 to 6 times out of 1 million chance of a severe allergic reaction that can be treated. So to me, that's the fundamental decision. You have to decide, am I going to be infected and take those risks, or I'm going to be vaccinated and take these risks?
Thank you for that. And we'll turn to our local health official and give her the last word. Dr. Haushalter.
Thank you, Wendy. I echo all the sentiments of the panelists, so I'll just add 2 other remarks. One, be an ambassador, so share the information that you have with others so they can make an informed decision as well. And lastly, really think about volunteering, not only driving someone to get their appointment, but potentially volunteering at a vaccine site. We need many people in this community to make this happen, and so volunteering would help as well. Thank you.
Thank you so much, all of you. I think it's important to stress that the decision is yours on whether to be vaccinated. We just want to make sure you have the right information to make an informed decision, but the decision is yours, and no one can force you to do it, but we want you to be prepared for whatever you decide.
Good evening, everyone. Wow, this has been quite an evening. It's been an evening of good, candid conversation, an evening of tough questions. I really want to thank our audience for being here tonight, but let me start by thanking Women United and Twan Stout Mitchell, and yes, Reverend Marilyn Robinson for conceiving this night. So I really want to thank Dr. Barney Graham, who enlightened us. It was in Dr. Graham's lab as the chief of the viral pathogenesis lab that this mRNA technology was first designed, and he worked in the institution of that first Moderna vaccine. Dr. Graham is the real deal. Dr. Graham has a personal story to tell, and he shared his expertise all the way from the NIH with us tonight. We've had an extraordinary moderator tonight, Wendy Thomas. She has challenged our panelists. Wendy, thank you so much for going that extra step and researching the issue before us this evening and driving this conversation. I'm believing that we are united together in understanding that when there is a vaccine available to us, we're going to be, as Dr. Graham said, first in line to take that vaccine. It is not a matter of whether one is better than the other. We're going to be in line to take that vaccine so that we can get past this. The United Way of the Mid-South, Women United, we have offered you this information tonight. Be encouraged, inspire someone else. Thank you so much for your time. Good evening.